one more thing before we talk about our case studies is patient history. So this is a really good way to help differentiate VT from SVT. So we can look at previously defined episodes, right? If a patient has had an episode before and somebody has defined that as VT or defined that as SVT, we should then compare the current episode that we're analyzing to that episode, right? What does the morphology look like to that comparative, to that previously defined episode? Does it have the same onset, the same termination? What about therapy? Was therapy delivered in either of them? Was therapy successful, not successful? That can tell us a lot of information about the particular episode that we're trying to analyze. I think it's also important that we don't forget the patient in this whole process, right? Talk to the patient. Did they have any symptoms? What were they doing? I always like to tell the story that I had a patient that I used to deal with that had a lot of episodes, and we would be looking at them and trying to figure out SVT versus VT. And finally, we just talked to the patient and we were like, okay, last Sunday night, what were you doing? And sure enough, it was a season ticket holder for the Patriots, and he was at the Patriots game, and he was getting really excited. And it was just an sinus attack. So, you know, again, important to talk to the patient. What were they doing? Were they having any symptoms? If they were feeling fine, it's maybe unlikely that they were in a VT. Maybe they were just in some sort of SVT. So understanding what's going on with the patient, looking at previous episodes is really important. And sometimes that can be kind of challenging to pull up previous episodes or to look at the presenting rhythm. So I just wanted to throw the screenshot in here of our remote monitoring software that actually has a pretty good feature, a pretty awesome feature that allows you to do that with limited clicks, really just one click. So you can see on the right-hand side of the screen is an episode that we're trying to analyze. And a lot of you guys would probably look at this and be like, oh, I don't know, SVT versus VT, the morphology is not quite the same, but it's irregular. Wouldn't it be great if I could compare it to the patient's presenting rhythm? Or wouldn't it be great if I could compare it to a previous episode? So our software actually allows you to just click this button here to say real-time, show real-time EGM, and it pulls up the patient's presenting rhythm from that report. So you can easily compare your current morphology to the patient's presenting rhythm and be able to pretty quickly identify VT versus SVT by looking at the morphology of a known episode. So now I'm going to hand it over, unless there's any questions. I don't see any on the question board. As always, feel free to throw them in. But for now, I'm going to hand it over to my colleagues Shand and Amanda, and they're going to take us through a couple case studies. So Shand, I'll let you take it away.
Thank you, Kate.
Yeah.
Like Kate said, my name is Shand Owens, and today we're going to take a look at a couple case studies. So case study one is a 57-year-old man with heart failure and a past MI, and it's a single chamber Medtronic ICD. So this case study highlights the importance of looking at a presenting rhythm. Usually these single chamber ICDs, not a lot of pacing indications in some of these patients. So there's generally going to be a V-sensing presenting EGM that you can take a look at and compare to a tachycardia in question. So if we look at this tachycardia EGM, we take a step back, it's regular. And then if we look at the tachygram over on the bottom right corner, it's a sudden onset arrhythmia as well. So these are two characteristics that we would associate with VT, but as soon as we pull up that presenting EGM on the near field RV EGM on the top, we can see that it's a pretty identical match. And based on that, we could confidently say that this is SVT. And then, while we're trying to figure that out, the device is doing its own work. If you could switch to the next slide. So the device did kind of the same thing we did. It compared a template that it captured at some point to the arrhythmia in question. And based on that, it assigned a match score. So if you look at the middle of this, the match scores from 82% to 76%. That was enough for the device to say, hey, this is an SVT. And then we were able to confirm that with a set of human eyes as well. I'm ready for the next one.
Yeah, great.
So the main takeaway here is use that presenting EGM and use the morphology to match with the arrhythmia in question.
Shand, one comment on that, if you don't mind going back to that presenting, is that I think sometimes people might be a little confused. around looking at the far field signal. And, one of the things to note here, as you mentioned here, is just to remind people about that the gain can be changed from one to the other. And so if you look at that, height or amplitude of the signal is not always something that you need to get too wrapped up around.
Right. The polarity is the same, which is really key.
Right.
Okay. Thanks, Greg.
All right, so case study number 2, it's a 44-year-old man with congenital heart defects and also a Lyme disease exposure. And this is a dual chamber Medtronic ICD. So this highlights the importance of looking at the onset and termination of episodes. So over on the left-hand side, we have the onset. We've got, kind of the meat and potatoes of the episode in the middle. And then on the right side, we have the termination. So let's take a closer look at this onset and termination here. So looking at this strip, it starts with the PVC and then it goes V to A all the way to the end of the strip. So you can confidently say here that the ventricle is driving this rhythm, which means that this is a ventricular tachycardia. And then if you look at the onset as well, next slide. If you look at the, not the onset, the termination, it ends with a V to A. So if we see a tachycardia that ends V to A, again, that ventricle is driving its VT with retrograde conduction. So based on the onset and termination, we can confidently say this is VT. And we get lucky after the termination, we have a 4-beat run of NSVT, where 3 of those beats go retrograde. And the morphology of those V to A's is pretty identical to the arrhythmia in question. So that further solidifies that this is VT. So if you don't have the onset or termination, and a lot of these rhythm strips that we look at do not have an onset and termination in the EGM. So if you don't have that, there's a couple, other tricks that you can use. So you can look at the atrial rate. So if you look over on the left side, the atrial rate is marching along at 170, 200 beats per minute, and then all of a sudden it drops down to 150. Well, that doesn't translate down to the ventricle. If the atrium was driving this rhythm, then we would see a break in the cycle length as well on the ventricle. But because the ventricle marches through at 170 and doesn't change when you have an atrial rate variation, we can confidently say something is VT. And the same thing applies over to the right. This is another part of the same strip. A little bit of undersensing going on, but in between that A blanking and atrial refractory marker, we see the atrial rate break, but it doesn't translate over to the ventricle. So again, the V is driving this rhythm, and we can confidently say that this is ventricular tachycardia. And then this is just another part of the strip. Now that we've confirmed VT, this is just the V driving the A.
So this is something that I tend to look at. I like to look for little spots in the episode where there's a little bit of rate variation and see if the rate variation one chamber also causes a rate variation in the other chamber. So before you were talking about, the atrial rate variations not being, translated to the ventricle, but here there's slight rate variations in the ventricle that are being translated to your atrial rate. So if we look at our cycle lengths, and this is something, I like to see on Medtronic because it gives you your A and your B cycle lengths. You can see the V to V interval at the beginning, 340, the next A to A interval, also 340. Okay, the next V to V interval is 360, driving the next atrial interval of 360. So you can see that in this strip. Every time there's a slight variation in the ventricular cycle length, it also drives the variation in your atrial cycle length. So at this point, we've already had quite a bit of evidence indicating VT, but this is just another piece of information, just another clue, another tip that you can use when analyzing these episodes. So onset and termination, if we have them, obviously morphology, if we have it, and then look at those the variability in your cycle length, see if it causes a variability in the opposite chamber as well, and help differentiate what's driving the rate.
And I think that's a really important point, is trying to bring as many clues to the table as possible. I know when we teach our students here, we say, imagine you're going in front of a judge and you've got to present your case, right? You never want to go to the judge with only one piece of evidence, right? And it's just the same way as we're making our clinical decisions. And that's why, going back to things like our early discussion on discriminators, it's rare that we're going to use something just like onset alone by itself, right? We want to have multiple pieces of data that's going to help us drive and use our decision. Great point.
So sorry, one more point. I just want to, bring everyone back to this first strip. But looking at this can be really overwhelming, and you might not know where to start. If you have the onset and termination, like Shan said, it's really great, but you don't always have it. And then, where do I go from there? Do I have to really analyze every single, interval? I think it's really easy for a lot of us to find an area that looks different. So, right, you can kind of zoom out a little bit and see, okay, this area looks different. Let's zoom in and see what's going on there. Here looks a little bit different. Let's zoom in and see what's going on there. And those are the two areas that Shan called out specifically, which show those rate variations, which indicate, VT. So again, it can be totally overwhelming, but you got to look for these areas where the rate changes, it stretches out, or things just look a little bit different. And then we have to, put on our detective hat, like Greg said, and figure out, why does it look different? What's happening there?